Hello, everyone, and welcome to Karan Academy. My name is Karan. I'm one of the final year medical students here at Monash, and I'm so excited and proud to be able to share this lecture series with everyone. It's definitely something that I've always wanted to do, and finally taking the time to do this. Although challenging, is also very rewarding. Today, we'll be kicking off our lecture series on cardiology with ECGs, which, as I'm sure you know, is very central to the discipline. At your year level, you should be able to, I guess, understand and be able to interpret an ECG in a systematic manner, as well as correlate that with the clinical findings of your patient. I'm sure you guys know how to do that to some degree, but hopefully here I'd be able to add a bit more to your clinical knowledge, explain the why, and add a bit of clinical context as well. Before we move on, I would highly recommend you guys watch the first video on the channel, which kind of explains and goes through how I would recommend using this as a resource. So let's jump into it. What we'll be covering today is starting off with some basic cardiac anatomy and its relevance to ECG findings. I think this is often overlooked, but I think it's good to go back to basics because it really does help put things into perspective. We'd be then going through kind of a systemic approach to interpreting an ECG, and then talking a bit about what can go wrong and why do things go wrong and why do they present the way they do on an ECG. Let's start with the coronary vessels. So as you know, you have two main coronary vessels on the left and the right coronary artery. These arise from the aortic sinuses, and these are the aortic sinuses seen here. These are tiny openings found behind the left and the right aortic flaps. The right coronary branch, as you can see here, gives rise to the right marginal artery, and this is the right marginal artery you can see here. And in most cases, in most people, about 80%, gives rise to the posterior IV artery, which is the posterior interventricular artery, which can be seen here. The left coronary on the other hand gives rise to the LAD, or the left anterior descending, which is one of the most important arteries, and we'll go through this in a bit as well. Gives rise to the left circumflex, and in some people gives rise to the posterior interventricular artery. So this artery, which arises posteriorly, can either be supplied by the right or the left, and there's a bit of a variation in that. And here's just a graphical or a schematic representation of what I've just talked about. Now let's talk a bit about coverage, because when we talk about coronary arteries and them blocking up in ischemia and heart attacks, you would never ever see an ECG mention which artery is affected right away. You need to know what parts each artery supplies and then how those parts show up on an ECG. I won't talk through this, but here are two very good diagrams taken from Teach Me Anatomy, which highlight the different areas of the heart supplied by the different arteries. Two areas that point to in particular would be the left ventricle as well as the interventricular septum. So considering that a major part of the heart's cardiac output is into the systemic circulation through the aorta, you know that your left ventricle needs to be very adequately perfused, and therefore any damage to this area, so any ischemia of the LAD or to the left marginal, can have very significant clinical consequences. So going back to basics, and I really know that this is a bit of a hated, controversial topic, but I really think that if you understand this once, you just don't forget it. So if we look at what an ECG is, think of it as just a surveillance camera. So each lead is a surveillance camera that is a really bad surveillance camera because it can just do one simple thing, which is tell you whether the cardiac impulse is moving towards it or away from it. That's all it does. However, if you have many leads put together, you can have a much wider picture. And that's all we want. We want a wider picture that is able to tell us the entire heart's electric activity. So let's make sense of what's going on. Let's start with the chest leads, because those are, I think, easier to understand. We have a V1 to V6, and they go across the chest. So V1 starts just lateral to the sternum, and they go across the chest to the left. So medial to lateral across the chest. Next, we have leads 1, 2, and 3. Now, these are your limb leads, and they're called limb leads because they go on your limbs. I hope that made sense. So what are the limb leads? So first, we attach electrodes, one here, and one on your left foot. The first lead is this one. So if this is negative and this is positive, it just looks at whether the heart's activity is moving in this direction or not. So if there was hypothetically an electric impulse just going from point A on your heart here to point B on your heart here, it would show up on lead one as a purely positive deflection, because that's all lead one would do, is look at how the electric activity is in this axis. Same for lead two, which looks at this, and then lead three, which looks at this. All of them go from negative to positive. I hope I haven't confused you so far just yet. Next, we have these weirder leads that are called AVF, AVL, AVR. Now, what do these stand for? So the A stands for augmented. Why are they called augmented leads? Well, because we aren't adding an extra lead to your belly button to look at the, we basically are able to generate these hypothetical or predict what this direction would look like. And that's why it's called an augmented lead, but it still has a lot of purpose, and we'll go through what that is. The F stands for foot, the L stands for left arm, the R stands for right arm. And now these just look at the heart's activity in the down direction, in the superior lateral, yeah, so superior lateral on both sides, one's to the left, one's to the right. Now let's look at the axis. As I said, the axis, what it basically tells us is, if you could summarize the entire direction of cardiac activity in one angle, what would that angle be? So let's just pause there and just look at this picture here. This is your heart, right? We know that the electric impulses in the heart start in the SA node, then go to the AV, then go through the bundle of His and Purkinje fibers and spread. If you look at it, the general trend is it kind of moves from here-ish and then goes here and then spreads, right? So the general direction of your heart's activity is in two ways. It's mostly going from this side of the heart to this side of the heart, and it's also mostly going down, but it's also going a bit to the side, but that's fine. But it's mostly in this quadrant would be the direction, right? And that's all that the axis is telling us. If for some wacky reason, let's say the heart's electric activity was mostly moving instead of like this, then, well, this would be the heart's axis, and that obviously is not okay. So let's look at how we calculate or look at this axis based on the leads that I've just talked about. As I said, what lead one does is purely tells us whether the deflections are more so in this direction, so from this side to this side, which would show up as a positive deflection, or from this side to this side, which would show up as a negative deflection. So let's look at just a case here. So don't look at this just yet because it's not relevant, but just looking at this ECG, as you can see, most of the deflection in lead one is positive, right? When we don't really have dips bigger than the ups. So this means that lead one is positive. Oops, went back a few slides. Yes, so this means that the axis is in this sphere, this hemisphere, and that's normal, right? So now we know it's in this half. The next thing we would look at would be AVF, because as you know, this looks downwards, and we want it to be in this quadrant. So now, just on the very same principle, if your AVF were to be positive, for both one and AVF to be positive, the axis would have to be somewhere in this quadrant, and that is normal. I will also tell you that we can tolerate about a 30-degree angle shift that's considered normal. Well, then that complicates things a tiny, tiny bit, right? Because for the axis to be in this direction, AVF would be negative, right? Because it's in this hemisphere. In that case, the other lead we can look at would be the one perpendicular to it, which, if you remember, is going to be lead 2. Lead 2 is going this way. It's going this way, remember? So again, if lead 2 is positive, that again means that the axis is somewhere on this half. Combining that with a positive lead 1 would give us an axis somewhere here, and that's normal. So let's go through that again, because I think I might have confused you. Step 1, look at lead 1. If lead 1 is positive, then great. If lead 1 is negative, that automatically means that the axis is on this side of the heart, which is always pathological. We'll go through what each one of those pathologies are in a second. We look at lead 1. Lead 1's positive, great. Look at AVF. AVF is positive, great. Your axis is normal. Oh no, AVF is now negative. Well, we could still have a normal axis. In that case, look at 2. If 2 is positive, great, you're normal. If 2 is negative, it means that the axis is somewhere in this red zone. And as you can imagine, that would be called a deviation to which side? To the left side. Now, that's a left axis deviation. Likewise, if you have AVF that's positive and 1 that's negative, your axis would be somewhere in this blue zone, and that would be called a right axis deviation. And that's all that is. Oops. Okay, yes. Now, looking at how each areas are represented on an ECG, you need to know which parts of the heart correspond to which leads. So, septal leads are V1 and V2. Anterior leads are V2, V3, and V4. Inferior leads are 2, 3 AVF. Lateral are AVL, V5, V6, and then posterior leads, which we don't really look at, are V7, V8, V9, which are extra leads we can apply under certain circumstances. Now, I've also mentioned which coronary arteries supply these areas. So you would know that the inferior part of the heart, which is indicated by leads 2, 3 AVF, is supplied by the right marginal artery. Putting all this together, what I would expect you to be able to deduce would be if you see a patient coming in with chest pain and has ST elevation and leads 2, 3 AVF, you suspect this might be an inferior STEMI, and you would know that the inferior part of the heart is supplied by the right marginal artery, which is where you would suspect the possible issue to be at. Right? That's what we're trying to get at. Okay, now some important points. While you interpret ECGs, you may be asked about some segments, which may be short or too long, and you can't really say, oh, it looks long to me. You need to know some specific values. And one value I'd recommend to remember would be 120 milliseconds or 0.12 seconds, which is also 3 small squares. This comes up a lot. A normal P-wave should be less than 0.12 seconds. P-wave morphology is also really, really important, and we'll look at the P-wave specifically in a bit. The PR interval is the time the electrical impulse takes at the AV node. In most cases, in most pathological cases, we see a prolongation of the PR interval, which means that there is some issue at the AV node. And well, what would you call that issue? Well, you'd call it a heart block or an atrioventricular heart block. And you need to know the different types of heart block. With the QRS segment, it can be either prolonged or narrow. In the context of a tachycardia, you can either classify this as a supraventricular tachycardia or a ventricular tachycardia based on whether the QRS complex is wide or narrow. The ST segment, we mostly look at elevation or depression. The criteria for ST segment elevation is 2 small squares in the chest leads and 1 small square in the limb leads. Now, why the difference? Well, if you think about it, the limb leads are much further away from the heart than the chest leads are. And therefore, for something to be significant, it should be showing up at a higher level in the chest leads than it should the limb leads. The other next important one is the QT interval, which is usually 440 milliseconds and should be less than half of the PR interval. We do not look at the QT interval in most cases, but instead look at something called the QTC, which is the QT segment, or the corrected QT interval. So QT corrected. Why do we adjust, or why do we correct the QT? Well, unlike many of these other parts of the ECG, which should stay the same with changing heart rates, the QT interval actually changes based on your heart rate. The higher the heart rate, the shorter the QT interval, and that's normal, right? And therefore, to call something abnormally prolonged, you obviously have to adjust for the heart rate. A prolonged QT interval can be seen in hypos, and this is really, really important. So hypocalcemia, hypokalemia, hypomagnesemia, and hypothermia. all cause QT prolongation. Actually, one of the patients I'm seeing these days on the wards has QT prolongation because of hypocalcemia. So it's a big one to know. Why is that a problem? Well, because QT prolongation puts you at a super high risk of ventricular tachys, especially torsade. It's called torsade de pointe. I can't pronounce it well. If you want to sound posh, go for it, please. I just call it torsades. And you can see shortening with digoxin toxicity. Now, this is the systemic approach to ECGs, and I would recommend that for the next year, my voice just cracked. That was really embarrassing. For the next year to use this system exclusively, you can always jump the gun and say, oh, there's a very clear ST segment elevation, but please go back and go through a systematic approach. I know people, and I've heard stories of people who failed ECG OSCEs because they've just gone in, said the ST segment abnormally elevated and left, and then got 1 on 20 because they missed out on everything else. So even though you know what's the prominent finding, please look for other stuff as well. So what can go wrong? Make sure you have the right patient. Make sure that the ECG is of a good quality. With rate rhythm, you can have regular versus irregular and tachybradyes. Axis, as we talked about earlier, left and right axis deviation. With P waves, you can either have no P waves, you can have something called P pulmonale or peaked P waves, and P mitrale or bifid P waves. And we'll go through this in a second. The PR interval, abnormally prolonged, as we talked about. QRS complex, there's so much going on here. I'm not even going to talk about this right now. ST segment elevation, depression, mentioned. T waves can be inverted with ischemia. You get peaked T waves with hyperkalemia and flattened T waves with hypokalemia, and then QT prolongation with all our hypos that we talked about. Starting off nice and easy, let's talk about rate and rhythm. Now, in most cases, the ECG strip you get has the rate on it, but do not trust it, especially not in front of a cardiologist, because they will make you calculate the rate. You can either multiply the number of QRS complexes you see by 6, and that's pretty good for irregular rhythms. If you have a regular rhythm, you can divide 300 by the number of, wait, hold up. Yes, sorry. So you divide, so you measure the RRs, so the R waves, and you divide, and you measure basically the large boxes. So if you have one large box between the two RRs, that's a rate of 300. If you have 5 large boxes between the RRs, when I say Rs, I'm referring to the R of the QRS complex. That would be 300 by 5, which is 60. Tachycardia is above 100. I'm sure you know this. It can be either physiological or pathological. The one thing you should always know of is a sinus tachy in an otherwise normal looking person who may be short of breath. Always suspect a PE. With brady's, they can either be physiological or pathological again. Some important ones you need to know are infarctions and medications like beta blockers and calcium channel blockers, which can both cause bradycardias. And then you need to ask yourself, is the rhythm sinus? And I know you get asked this a whole bunch, but I personally didn't understand sinus rhythm for a long while. You need to ask yourself, are there P waves present? And are they present consistently? Is there one P wave before each QRS complex? Is there a QRS complex after each P wave? And are the QRS complexes normal? If the answer to any of those questions is no, then this is not sinus rhythm. Just know that. So don't be quick to call something sinus. So what could be the issue? If you don't have any P waves that's typical of AF or atrial fibrillation, absent P waves with a broad QRS is usually a ventricular issue, typically a ventricular tachy or a fibrillation. Absent P waves with narrow QRS is usually a supraventricular tachycardia. If you have a baseline with a saw-like appearance, that's atrial flutter. And if you have P waves that are not followed by a QRS complex, or you have missing QRS complexes, worry about AV blocks. We've already talked about axis and how to calculate this, but what you need to know is left axis deviation is very commonly seen with left ventricular hypertrophy. I hope this makes sense. Why? When your left ventricle is hypertrophied, it's going to require more electrical inputs, and therefore that's going to shift the entire axis of the heart towards the left. Therefore, left axis deviation. Same logic can apply with the right side as well. And when you see right ventricular hypertrophy in isolation, you should worry about things like pulmonary hypertension. Okay, so let's go through this really quickly. Pause the video, look at this, try to figure out the axis based on this diagram. Pause, okay, go, let's talk about it. First thing, as I said, look at 1. Oh no, 1's already negative, this is not good. Next, we look at AVF. AVF is mostly positive. So when I say negative and positive, I mean, if you look at 1, is it more negative or is it more positive? So this is clearly more negative, and this is clearly more positive. So where does that put us? 1 is negative, which means it's somewhere in the left hemisphere. And AVF is positive, which means it's somewhere in the lower hemisphere. The only one that fits is this blue part. And anything in the blue part would be, by definition, a right axis deviation. Cool. I hope that made sense. Let's look at another one. Here we have 1 being clearly positive, AVF being clearly negative, and then you think, oh, at this point, I know that it is in this, it is between 0 and -90, but is it between 0 and -30? Let's look at lead 2. And lead 2 is, oh no, it's also negative, which means it's between -30 and -90. And that puts us at a left axis deviation. Ah, cool, moving on. Now we have the P waves. If you have P waves present and followed by QRS complexes, that's sinus. If you have absent P waves, that's atrial fibrillation. If you have P waves that do not match with the QRS, consider a heart block. Now, there are 2 conditions that I want to quickly explain, and I want to explain why we get them. Those 2 are P pulmonale and P mitrale. So, wait, do I have a picture? Okay, wait, let me explain these 2 first. So peaked P wave is when your P wave literally is like much taller than what it should be, versus bifid, and it kind of looks like this. And this is what it kind of looks like. Okay, so let's talk about why that happens. And I felt so smart after knowing this. I learned this like end of 3rd year. So yeah, it wasn't a fun year for me. Okay, so what does the P wave represent? P wave represents atrial depolarization. Be clear on that, right? Most of that depolarization is going to start off in the SA node, which is going to be on which side of the heart? Hope you know. SA node is found in the right atria. Cool. Now, let's say that for some reason, your right atria has become much larger and hypertrophied than what it should be. We'll talk about the causes later, but just assume that it's bigger and hypertrophied now. What is that going to cause? Well, that's going to cause more depolarization, which is going to appear as a bigger peak. And as we know, most of the P wave is originating from the electric impulses of the right atria, which is why we're going to have a much bigger or peaked P wave. Next, let's look at bifid P waves. And why would you get something that's notched like this? As we said, most of the electric impulse starts in the right atria. However, if for some reason you have hypertrophy of the left atria now, you're going to get an initial depolarization from the right side. And by the time it reaches the left, you're going to have another big depolarization because now the left side is also hypertrophied. So you're going to have big peak, versus normally where the 2 peaks kind of overlap and you get kind of a normal looking ECG lead. So quickly going through that again. If you see here, this diagram, the blue is the P wave that appears on the ECG. The red is the right atria. The black is the left atria. When the right atria hypertrophies, you see a big overlap because that's where most of the electric impulse is coming from, causes big P wave. When the left atria hypertrophies, you get kind of separation and you get this peak, and you get these two peaks. Now, what causes each one of these? As I said, your heart hypertrophies when it pumps against resistance. Now, hopefully this makes sense. Well, what valve would they be pumping into? Well, you know that the left atria would be pumping blood across the mitral valve. If for some reason the mitral valve is, let's say, stenotic, and it's having difficulty pumping blood through, it's going to hypertrophy. It's going to hypertrophy. It's going to cause this. And oh, that is why it's called P mitrale, because the issue is typically with the mitral valve causing the hypertrophy, causing the ECG change. Same, with the same exact reasoning, it is typically the pulmonary valve in this case that causes backflow of blood due to pulmonary pathology like pulmonary hypertension or tricuspid stenosis, that you have this backflow, which causes the right atrial hypertrophy that causes P pulmonale. I realize I've spent way too much time explaining that. Anyway, going through these. So what is this? I'll just spare you some time. Pause if you want, go through these. So this is normal sinus rhythm. What's this next one? Can you see P waves? I cannot see P waves. This to me looks like this to me looks like AFib. Next, we have this lovely sawtooth pattern-like appearance with a 3-to-1 conduction pattern. What I mean by this is you have boom, 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 QRS, boom, 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 QRS. That's a 3-to-1 block. Next, you have these P waves, but these P waves look abnormal. And you just learned that bifid P waves are called P mitrale, and these peaked P waves are called P pulmonale. Okay, moving on. We have now the PR interval. And the PR interval is the time it takes for the signal to move from the SA node to the ventricles. I hope that made sense, because we have the QRS complex. The P wave is depolarization of the atria. QRS is of the ventricles. So anything in between, that is the time it takes. It should usually be less than 0.2 seconds or 5 small squares. I would recommend you know this. Anything greater is considered an AV block or atrioventricular block. First degree blocks is where you have a prolongation. And as you can see here, there is a prolongation. This is the P, this is the QRS. Let's say it's 360, that's prolonged. It should be less than 200 milliseconds. However, this prolongation is continuous and it doesn't change. And you still have all your QRSs. It's just a bit longer. That's first degree. It's commonly seen in coronary artery disease, where in most cases asymptomatic and you don't need to treat this. With second degree heart blocks, you have two types. You have Mobitz type 1 and Mobitz type 2. Mobitz type 1 is also called Wenckebach. With Mobitz type 1, you see that the PR interval keeps elongating, and then you drop a beat. And then again, normal elongating, drop a beat. And that is shown here. So you have 260, 280, 320, boom. 260, 280, 320, boom. And that's what I'm talking about. With Mobitz type 2, you have the same longer patterns similar to first degree heart block, but instead of having consistent QRS complexes, you just drop a few. So you have continuously prolonged, drop, continuously prolonged, prolonged, drop. And this is usually every third or second beat. And Mobitz type 2 in most cases is pathological, while Mobitz type 1 often isn't. Third degree heart block is pretty bad. It's seen in all cases of all infarcts, where you have significant fibrosis and blocks, and most third degree heart blocks do require treatment. When it comes to treating heart blocks, oops, I should have something on it in a bit. Oh no, I completely realized I have a whole entire lecture on arrhythmias where I go through the treatments, which we won't talk about treatments here. We'll just talk about the ECG side of things. For that, look at presentation number 2. All right, so what's going on here? So identify the heart block. So what's going on here? We have prolongation, a bit more for prolongation, bit more, then drop. What is that? That's going to be your Mobitz type 1 or second degree AV nodal block type 1. What is this? Now, long, super short, missing, long, it's completely disorganized. And this is your third degree heart block. Funnily enough, I mean, it's not funny, it's interesting, not funny. If you were to look at the P waves and the QRSs, they're actually pretty regular. So we have P, 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 P. The P's are regular. QRS, QRS, QRS. QRS is also regular, but they're not talking to each other because something has gone so wrong in that AV node that there's just no conduction between the two. Next, we have this where you have continuously prolonged PR intervals. However, you don't have drops in the QRS complexes, and that's normal. Sorry, that's not normal. That's your first degree heart block, sorry. And then you have this where you have prolonged drop, same prolonged drop. That's a second degree atrioventricular block that's of a Mobitz type 2 pattern with a 3-to-1 rate. Now, this is the whole description. If you can just get to second degree type 2, that's already exceeding expectations. Oops. Okay, QRS pathologies. Now, we can have two issues. They can either be too narrow or they can be too broad. And typically, when we talk about too narrow, we are talking about the space between, sorry, the duration of the QRS being less than 120 milliseconds, that is 0.12 seconds, which is, again, 3 small squares, magic number. This can be normal. However, if this is abnormal or if this is present in some pathological case, the issue is not at the level of the ventricles. The issue is supraventricular. And this can be in the form of SA nodal issues, issues at the atria, issues at the AV node, reentry tachycardias, AVRT, AVNRT, but that is future use problem in 2 days when you look at the other lecture. I'm sorry. However, if you have a QRS complex that's super broad, that's more than 120 milliseconds, there is definitely a pathology. Most typically, this is going to be a tachycardia of ventricular origin, your VTAC, VFib, as well as ectopics. With a bradycardia, you can have a bundled branch block presenting with a bradycardia. What I want to talk a bit about is R wave progression and identifying left and right ventricular hypertrophy. Again, I think one of those concepts easy to memorize, but easier to understand. So, just going back to simple basics, V1 to V6 go across the chest. V6 is going to be lateral on your lateral wall, looking at the left side of the heart. V1 is going to be anterior, right? What does the QRS complex represent? I hope you would be saying out loud, well, it represents ventricular depolarization. Perfect. Where are most of your ventricles going to be? Well, Karan, I have a left ventricle, I have a right ventricle. Fair enough. Which one's stronger and which one has more muscle? Well, I think it's the left one, and you'd be right, because it's pumping blood into the systemic circulation. Okay, so now we know that most of the depolarization is going to be happening in the left ventricle. Well, okay, where is the left ventricle going to be? Is it going to be more anterior near V1, or is it going to be more lateral near V6? Well, it's going to be more lateral during V6. Perfect. Which is why, if you look at the normal progression of the R wave, it's going to be positive, or it's going to be positive in the lateral leads, but gradually going, you're going to have a negative or a deep S wave in V1. So you see tall R waves in V6 and deep S waves in V1, and this is normal. Again, now what does the S represent? Well, S represents why do we get these deep waves in V1 or V2? Well, it's because it kind of mimics the other way around, right? So if you have depolarization here, this part goes up, but this part goes down. I hope that made sense. I don't think it did, but it is okay. I shall move on. Now, let's say we have left ventricular hypertrophy. I know I have right first. I'm sorry, but let's talk about left first. If you have left ventricular hypertrophy, if I were to ask you, random person listening to this right now, Would we expect the R wave to be taller in V6 or V1? Just based on what we just said. I hope you, at this point, you're thinking to yourself, well, we know that the left ventricle is going to be more near V6, and which is why we're getting the tall R waves. So if there's more ventricle, we'd probably get taller R waves in V6, and you'd be absolutely right. Meanwhile, you'll also be getting deeper S waves in V1, because again, of that reciprocal issue. And therefore, we add both of them up to have the criteria for left ventricular hypertrophy. There are quite a few criteria, but the one you need to know is R in V6 plus S in V1 is if it is 35 mm or greater or bigger than 7 big squares, that is left ventricular hypertrophy. And the exact opposite for the right ventricle. The right ventricle, this is the acute depolarization of the right ventricle, right? And this is the reciprocal change. Again, tiny, right? Therefore, we look at the R in V1 plus S in V6, and if this is greater than 10 or 2 big squares, that's right ventricular hypertrophy. And I hope at this point you can appreciate why we have the difference in the numbers, because the left ventricle inherently is much larger and has a much larger depolarization pattern than the right. So what is going on here? So let's just look at this. You have, okay, so let's assess for both, because obviously we're just starting off and you don't know, and you don't even know what's going on here. So I would still hope you go through a systematic approach. By the time you're coming in looking for hypertrophies, let's start with left ventricular hypertrophy, just because that's more common. So we said, we look at the R in V6, which is about 1 big square, and then we look at the S in V1, which is about half a square. You can also look at the same number in V5 and V2, but you need to look at the opposite leads. So either look at V1, V6, or V2, V5. So even let's look at V5 and V2. So we have about 1, 2, about 2.5 big squares of R here, and we have 1, 2, about 2.5. That's a total of 5. That does not meet the criteria for left ventricular hypertrophy. That's 7, right? So we don't have left ventricular hypertrophy. Now let's look for right. Again, we're going to be looking at the R wave in V2 plus the S wave in V6. And that's 1 big square, 2 big squares, 3 big squares, 4 big squares, 4.5. There's half here, that's 5, and then 6. You have 6 big boxes adding up the R in V2 and the S in V6 in, sorry, we should go for V5, my bad. So 1, 2, 3, 4, 4.5, 5.5, about 6.5, right? What was the threshold? It was 2. The threshold for RVH was 2. We have 6.5. This is right ventricular hypertrophy. Now let's look at this one. Again, let's look at V5 and V2. So we have 1, 2, 3, 4, 5, 6, 7, 7.5, almost 8 big boxes. Adding them up, that is clearly LVH. Just to be double sure, let's also check for RVH. So we have 1 big box and about a third. So 1.3 big boxes. It's not 2, you don't have RVH. That's LVH. Now let's talk about bundle branch blocks. Now, what is a bundle branch block? As we know, after the SA node, after the AV node, we have our 2 bundles, right? One goes to the left, one goes to the right. If either one of them get blocked, that's a bundle branch block. Whenever you suspect a new onset bundle branch block, particularly a left bundle branch block, always suspect an AMI unless proven otherwise. Because for the left branch to suddenly not conduct, it is usually an ischemic issue with the left anterior descending artery. Now, how does this present? So the way you can remember this is William and Marrow. So you would see a W morphology of the QRS in V1 and an M-shaped morphology in V6, and the opposite for right bundle branch block. But more importantly, what I've always found to be an association is look at the T wave. This is often very hard to distinguish on an actual ECG, but if you look at the T wave, that often is a big tell as to which part's affected. If I have some abnormalities, which I can't tell if it's a W or an M because ECGs don't look like buzzwords, but I have T wave inversion in V5 and V6. That's going to be a left bundle branch block because V5, V6 look at the left bundle in particular. Next, let's look at ST segments. So this is your go-to segment when you are suspecting a STEMI or a heart attack. The normal ST segment is less than 120 milliseconds isoelectric with the baseline. And you can see elevation, obviously, with occlusions. We talked about why we have different thresholds for chest and limb bleeds. And you can also see depressions in partial occlusions. And the threshold for a depression is more than one small square. If you ever see global ST elevation, that's pericarditis, and this is a very common third-year exam question, and a downward sloping ST segment is digoxin toxicity. So this is an ST elevation, and very often you might get a reciprocal change in the opposite lead. So AVL is the kind of opposite lead for 3, and you can get a reciprocal change. So don't always look at this and like, oh, it's ST depression in AVL, let's just go there. No, always look at the other ones and ask yourself, could there be an elevation for this depression? Next, we have T waves, and we're approaching the end of this. I'm sorry if this is taking too long. The normal T wave is, again, less than 120 milliseconds, but more importantly, we want to look at the P wave, the T wave morphology. The first thing is inversions, which commonly indicate ischemic changes. The exact cause of which can be a few things. It can be post-MI. You can also have T wave inversions with right ventricular hypertrophy and left ventricular hypertrophy. Now, that may be a bit confusing. Well, why are we getting inversions? Well, inversions, they still indicate ischemic change. Well, why am I getting ischemic change with LVH? Now, remember, you have muscle that's grown without much change to the blood supply. And a person with heart disease that's having LVH probably already has a degree of vascular compromise. So now you have much more muscle supplied by a little less blood. So you're going to have something called a relative ischemia, where you still have blood flowing, you don't have an acute occlusion, but just because of the pure size of the muscle, it's not going to be getting oxygenated as much as it should, and therefore can present with T wave inversions. I can go into the pathophysiology of why you get the inversions, because there is a positive movement of potassium ions out of the cell as the cells are dying, typically causing firstly a T wave peak and a T wave inversion afterwards. But I think that's just too high for your level. You need to know that hyperkalemia can present with peaked T waves, and hypokalemia presents with flattened T waves. Typically, when we have an acute MI, in most cases, first you get the peaked T wave before you get the depression. Why? And again, this is one of those things that kind of blew my mind and also made me realize how little it takes to get me excited. When you undergo ischemia for myocytes, the first thing that they start doing is, well, you have compromise of the myocardial membrane, right? And you know that ideally potassium should stay inside the cells and not outside the cells. But with an MI, you lose that function. So potassium, the first thing it does is it starts leaking outside of your cells. And it appears almost as a hyperkalemic picture, as your cells are losing potassium and they cause excessive depolarization, causing this peaked T wave, which eventually goes into a flattened and then a inverted T wave over time. Now, the question is, well, why don't we see these peaked T waves when we look for MI changes? Well, because this happens so quickly, it's almost unlikely you're ever going to catch this unless you already had an ECG attached while the patient had a heart attack. Now, understanding echocardiograms. Now, this is just a one-page, very quick guide. Not thorough in any way or form, but what is an echocardiogram? So it's a type of ultrasonography, which is specifically used to assess different parts of the heart. So what can we look for? We can look for valvular defects, so our stenoses and our regurgitations. We can look for new vegetations and growths, specifically with infective endocarditis and rheumatic heart disease. We can look for ventricular hypertrophy with LVH, RVH, measure the thickness of the walls, measure the cardiac output, measure the ejection fraction. We can look for emboli with atrial fibrillation. We can look for heart wall dynamics to look for areas of hypokinesis, typically indicating a past infarction to that area. We can do a lot of them. And there are two broad kinds of echoes you can do. You can do a transthoracic, which is through the thoracic wall, or a transesophageal, where you put the probe inside the esophagus to then look at the heart. And a very common question you would get is, oh, Karan, what type of echo should I do if I'm suspecting infective endocarditis? Or, well, what type of echo should I do for this or that? Very, very simple. Obviously, there are surgical and procedural considerations, but in an ideal world, this is why we do certain things. We cover infective endocarditis and all these conditions a bit later, but it all goes back to what we want to look at. Remember, the heart is positioned this way. It's slanting forward. And so you have certain valves that are more posterior and certain valves that are more anterior. As you can see, the apex of the heart is very anterior. The left ventricular wall is going to be rather anterior, versus valves like the mitral valve and the tricuspid valve are going to be more posterior, while aortic and mitral and tricuspid, aortic and pulmonary are going to be more anterior. The reason you are doing your echo is really, really important. Let's take an example. I have a patient who I suspect is in heart failure. With heart failure, the few things I'm worried about is A, does he have left ventricular hypertrophy? B, what is his or her ejection fraction? C, do they have a valvular defect like aortic stenosis? So going back to what I said, do they have left ventricular hypertrophy, left ventricle close to the anterior side? Do they have ejection fraction issues? Again, the aortic valve that's going to measure that more anterior, and aortic valve defects more anterior. And therefore, in that case, doing a transthoracic echo, where we are closer to the anterior side, is going to be more beneficial. Versus if you want to look at things like infective endocarditis and rheumatic heart disease, which are typically going to affect so infective endocarditis, as you know, most commonly affects the mitral and tricuspid, while rheumatic most commonly affects the mitral. All of these defects are going to be visualized much better with a transesophageal echo. And therefore, you should never rule out infective endocarditis vegetative growth with the transthoracic, because you may just be missing it. And therefore, going through the esophagus and looking more closely at the posterior half of the heart is going to be more beneficial. And that's all we had for ECGs and the tiny, tiny touch on echoes. Thank you all for coming. I'm really, really excited for this. If you have any questions about what I've gone through, or advice, or anything med or non-med related, please feel free to get in touch. Add me on Facebook if you'd like. And as always, please look after yourself. This is a hard course. It's a hard year. You're in for the long run, and very commonly, a lot of the things that us as students go through are not superficially seen, especially mental health conditions. So please, you never know what your nearest and dearest friend is going through. So seek out, say hi, be nice to others. People have it hard enough. Yeah. And yeah, I'll see you guys in the next one. And next up, we have a lecture on arrhythmias.